Okay, well, I'd like to thank Rupert and also Sarah for all your work in getting this together. It's really been wonderful to have this exchange over the last 3 days. Very much appreciated. And I'm going to be talking about a single ascending dose study for the most part for a compound that Gilgamesh is currently actually has started a phase 2 trial. And this is the SAD trial that we conducted at CHGR in the Netherlands. And we have some background here. There's no reason, I'm not going to go through this in detail because this was just published earlier this year in neuropsychopharmacology. But basically the idea is that GM-1020 binds with about the same potency as R-ketamine. It's actually an R enantiomer related to ketamine and exhibits voltage-dependent block of the NMDA currents, and also has high bioavailability in rats. So the ideal is we were making this to have an orally administered NMDA antagonist. It has oral antidepressant efficacy in rats. If you look at the chronic mild stress paradigm and looking at sucrose intake, and then when you actually look at the exposures that are seen in that model, plus the exposures seen to get ataxia, it seems to have some sparing of about a 20-fold margin in terms of doses that cause ataxia. So the ideal is it's an orally bioavailable NMDA receptor antagonist with antidepressant efficacy in preclinical models at exposures that don't produce unwanted motor effects. And then this is just the typical SAD that we conducted, in which we looked at 6 different dose levels ranging from 20 to 360 milligrams. And they came into the clinic, and we had cohorts of 8 patients per 8 healthy volunteers per cohort, 6 on active, and 2 were on placebo. And then they were dosed on day 1, and then followed through day 2, and then were discharged. And then we had a follow-up in day 14. So we're looking typical safety measures, indirect target engagement measures, such as looking at resting state EEG and also PK, and the usual subjective effects with things like 5-DASC, MEQ, drug effects questionnaire, bond and later. And then also looking at pharmacodynamic effects, objective pharmacodynamic effects, looking at neurocart to look for sedation as well as ataxia. And then some also other things that we did in the study, looking at reward function, but we won't discuss that. And this just shows the PK of this compound. And what you see then is that we have actually, in terms of the linear scale, we actually have nice dose-related increases. And then if you look at the semi-log scale, you can see roughly we're having parallel increases with dose, which is showing that we're getting dose proportional increases in PK. And also, as you can see, that there's relatively modest variation here. The Cmaxes that we're seeing, the percent CV is, for the Cmax is 20% or less at doses through 220 milligrams. And we also see a half-life roughly about 4.3 hours as well. So those are the PK characteristics that we see. And then this just shows some of the EEG effects. And you heard about that yesterday in terms of the ideal that for NMDA antagonists, you see suppression at the alpha band, and we see that both with eyes open and eyes closed. And then you're also particularly seeing increases in the gamma band activity, both for eyes open and eyes closed. And this was for the time point of 1 hour after drug administration. And the next slide just shows you the actual dose and time-dependent effects on EEG. And what we see here again is that when you look at the alpha and the eyes open at the 1 hour time point, the doses of 60 milligrams and above are actually having the suppression of EEG band activity. It's a little bit more divergent for the eyes closed, but for eyes open is particularly sensitive for seeing these suppressant effects on the alpha band. And then we also see on the gamma, we see dose-related increases, particularly for the faster activity. We're not showing the 360 milligram dose here because at the 360 milligram dose, subjects were actually having a little bit of time following directions to keep their eyes open or eyes closed. So the data wasn't quite as reliable, and we only had 2 subjects, and it sort of distorts things. So that gives us hope that beginning at doses as low as 60 milligrams, it appears that we're seeing some clear CNS effects that can be related to engagement, particularly of NMDA receptors. And then this just shows you some subjective effects, gives you an idea of the time course that we're seeing. This real-time intensity scale has been developed, and actually Timmerman used it to show effects on psilocybin. And what we're looking at is sort of the total intensity of the subject's experience, which is an average of what you see for effects on bodily function, visual intensity, and also emotional metacognitive effects. And then you can see that we really have a dose-related effect, particularly through 30 minutes and 1 hour. And then the effects largely dissipate to the most part by the time of 4 hours. Their decrease are already at 2 hours. And then this just shows a more traditional measure for looking at alterations of consciousness, which is in this case the 5-dimensional Alter scale of consciousness. And there are 5 different dimensions that are looked at here. And what we see is a nice dose-related increases. Okay. For the anxious ego dissolution, auditory alterations, oceanic boundlessness, reductions in vigilance, as in visuary restructuralization, with the largest effect being at the 360 milligram dose. And this instrument was really sort of derived from earlier instruments in which the idea was that coming up with an instrument to measure alterations in consciousness, whether that was through drugs like ketamine or 5-HT2A agonist, or non-pharmacological interventions like sleep deprivation, and also the effects you see in psychosis as well. And these measures were measured like essentially 6 hours after the drug was administered. And we also saw effects on CADS, as you would expect, in a dose-related manner. But note is that the effects at doses of 140 milligrams are really somewhat modest. In contrast, what we are seeing, is when you get up to a dose of 220 milligrams, it's roughly in the range of about 6, 7 or so. And then going up in dose to 360 milligram dose, we're getting up in the range of 19 or so. So that's clearly a range that you're, like for example, I'm showing some comparisons to patient data. So the caveat here is we're comparing healthy volunteers to patients. But nevertheless, for the Pharma study, a 0.5 milligram per kilogram IV dose led to a level of about 13 on the CADS. And then also for the esketamine pivotal trials, the median CADS in those studies ranged from about 6 to 9.5 as well. So which is somewhat roughly of what we actually see really for that 220 milligram dose. And doses below that, the 60 to 140, have really a very modest 2 to 3 point increase on the CADS. And I'll show you a little bit more CADS data for the categorical at the end. And this is just showing the treatment emergent AEs reported by at least one participant. Of note, there were no SAEs in this study, and there were no severe treatment emergent AEs. Most of the AEs were actually of mild sort. But if you look particularly at the top at all events, you can see a nice dose-related effect in terms of the number of events and also the number of percent of subjects actually expressing events at each dose level. That's also seen as well when you look for all the nervous system disorders, SOC, shown here. And you can see this dose-related effect. I'm not going to go through the rest in detail, just showing that for completeness. And the same thing, looking at the psychiatric disorders, SOC, as well. Again, showing at the top is all events, the number of treatment emergent AEs, dose-related, and the same thing for the psychiatric disorder SOC as well. We see clearly seeing this dose-dependent increase. And then, in addition, from a safety standpoint, we see things that you would expect from what we know about ketamine. There are increases in blood pressure. And the measurements we have here are a little bit variable because we only did singleton blood vital signs for our study. The study was sort of packed with things, so it made it a little bit difficult to do much more than singleton measurements. But you see clearly there are these increases, particularly at the 360 milligram dose, and somewhat lower increases for the 220 and the 140 milligram dose. Those are increases roughly about 8 millimeters of mercury, roughly, compared to placebo. So that's sort of roughly comparable to what is known from the package insert when you look in the patient population for esketamine. And then this is just getting back then to the incidence of CADs. What I've done here is that we're looking at sort of an aggregate of the data, combining the data from the SAD, the MAD, and also a food effects study that we did. And here, what we're doing is indicating the incidence of CAD scores at any time point in a patient after they've been given GM-1020. And we're using this cutoff as 4, which people have described before, because Doug Bremner and his colleagues at Yale described that as seeing that at any time point is suggestive of is an abnormal score. And what we see here clearly is this dose-related increase in the CADs, that at doses of 140, it's really pretty modest, around 26 or so, and quite a bit lower for the 60 and 100 milligram doses. And those were doses where we clearly saw signs of EEG engagement on the resting state EEG. And then at these higher doses, we're getting in the realm of what you would see for esketamine or ketamine. One caveat about that is we're showing roughly the amount of CAD scores greater than 4 in the label for esketamine, although it's a little bit lower than that if you adjust for placebo, because about 5 to 16% of the subjects in those studies actually had CAD score greater than 4 as well, which isn't surprising for a depressed population, and the fact that some of those have trauma in the past as well. So this just sort of leads us into what we've seen from the phase 1 results is that oral administration of GM-1020 exhibits PK, safety, and tolerability, and PD effects expected for an NMDA receptor antagonist. And we appear to have a window, perhaps a sweet spot, of around 60 to 140 milligrams that we hope will be relatively safe with respect to things like sedation and dissociative events. And so we've actually started a phase 2A study currently. It's being conducted at the MAC Clinical Research Centered in Manchester, and John Connell is here in the audience as well. And what we're doing in the study, the first part of it is we're looking at a crossover study where we are giving a moderate dose versus placebo. And we're doing that just simply because of the frequency in which this kind of paradigm has shown effects when you look at a meta-analysis. It shows a little bit bigger sized effects for some reason than the parallel group randomized studies. But after we look at that first part in this moderate dose of GM-1020, and then all these patients are being randomized. So it's not quite apparent from here, but these patients will be have been randomized to either a moderate dose or a high dose. and vice versa. So all the subjects will be getting 2 weeks of GM-1020, where they're getting it twice a week. We just wanted to get some initial experience on what multiple doses do in a depressed population. And then we'll be following them out through day 67. So essentially what we're doing here is we're looking at things such as patient verification, using the SAFER system to try to ensure that we're getting true depressed patients in the study. We're also looking at objective measures to look for potential stratification and also look for drug effects with high density 64 lead EEG. In addition, we have sort of multimodal things that we're looking at. We're looking at the 5D ASC to understand the nature of the effects in the individual patients. And then we're looking at the CADS, MOAS, and then also reward function and the facial emotion recognition task developed by Catherine Harmer as actually additional measures of surrogate clinical efficacy as well. We're also doing some other things looking at sleep monitoring, heart rate variability, activity, and daily subjective assessments that we're following in this period out here after the last dose has been administered, so we can get a somewhat of a handle on when relapse may be occurring. And acknowledgements, I'd just like to thank the rest of the Gilgamesh clinical team and all of the Gilgamesh team, including Jonathan Sporn, who's in the audience and is our CEO, and also thank our colleagues at CHDR who conducted this study, including Gabriel Jacobs, who is the PI. So thank you very much for your attention.
Fantastic. Any questions?
Hi, thanks for the really interesting talk. It looks like a quite an interesting compound to follow. So what I'm wondering about is, if I'm correct in the chemical structure, I think this is basically 4-FDCK, right? And so I was wondering if you could speak a little bit as to what led you to the 4-fluorinated substitution compared to, for example, what's been already investigated, like 2-FDCK, and yeah, whether that's something that was chosen kind of on purpose for any particular reason.
Well, Andrew Krugel, who is the CSO and in charge of the chemistry, he basically looked at the structure and looked for what would probably result in better oral bioavailability. And then there were obviously a number of compounds in the SAR that were looked at. And so that hasn't been fully disclosed yet, though. But yeah. But
okay, cool.
I mean, the chemical structure has been disclosed in our manuscript, though. So yeah. There's it's even lower affinity than ketamine, than either R or than S-ketamine or racemic ketamine. Yeah.
Any other questions? Great. Okay, thank you very much. Fantastic talk.